Hey, wait, if I have to give you a kiss or I'm not. You're doing it once. What is that? Wait, what's the name of the song? Anything No Filter South Africa. Saturday.
are held under arrest.
Good evening, everyone. Please, can you hear me? Confirm if you can hear me.
Loud and clear.
Yes, we
Okay.
can hear you, ma. We can hear
Good,
you.
good evening. Good evening, everyone. Trust our day went well.
Everything is okay, ma.
All right. Thank you, sir. Glad to hear that. So, it's already 8:30 and we just have 27 persons here present. So please, if you have a colleague, a friend that is meant to be on this call and he or she's not here yet, so please do well to send a hi to the person because our facilitator is already ready for us. As you can see, she has shared her screen already. So please let's just use like 5 minutes to invite our friends over. And after 5 minutes, that will be by 8:36, we'll kick off. Thank you. Hmm? Please kindly mute your mic. Check if your mic is unmuted and mute it, please. Thank you.
Na shiga. Kenan a yan ma attendance ne na riga na shiga yanzu. Sau uku suke ɗauka attendance. Da farko.
Please mute your mic. Amina, please mute your mic. If you are just coming in, please check if your mic is on and please mute it. Thank you so much. So we have like 3 minutes more to go and we'll start the class.
Kai ka tafi goyel ɗinka da Allah zan yi lecture karka da mai goyel ba ku ba da kuɗi.
Okay, so it's 8:36 already. So our facilitator today is Dr. Aike Stella. Yes. And she's so special to me. Let me just say she's so special to me because I've drunk from her well of knowledge. So please, I encourage us all to give attention to today's class. Yeah, she's able and she's capable. If you have any question, get it ready because she's capable to take your questions. So, Ma, are you ready for us?
Yes, I'm ready.
All right, Ma, you can have the floor.
All right, thank you, the presenter. I want to start by introducing myself. I am Haike Stella Ifeanyi, as she rightly said. I am the Deputy Director of Physiotherapy, UNTH. I am here to present documenting information in rehabilitation. Documenting information in rehabilitation. The objective of this presentation is educating on what documenting information in rehabilitation really means. We really need to know what it means. Also,
Hello, Ma. We can't hear you. Please, unmute your mic so we can hear you speak. Okay.
I'm unmuted now. You can hear me now?
Yes, we can now.
Can you hear me now?
Yes, we can hear you, Ma. Go ahead.
Okay. Okay, the objective of this presentation is aimed at educating on what documenting information in rehabilitation really means. And also we are going to talk about the policies and the procedures for the storage of information in rehabilitation and standardized formats for documenting information in rehabilitation. You know, in the course of our seeing our patients, in the course of our assessments, our management, in the course of our patient intervention, there are a lot of things that we don't really think they are important, which may cost us a lot of things. So I crave your indulgence to really pay attention and understand some of all these things. You know, this time around that, you know, the internet is there, patients are knowing their rights. There are things you may do that may cost you a lot of problems. Yes, your intention may be to do, you know, to do things that will benefit your patients, but the patient may understand it in another way. And some patients, some evil people may want to make money out of it. So we really need to pay attention and understand a lot of things that we really need to do and maybe put into our practice so that we want to protect ourselves. Another way for our patients, you know, to the things that will also yield better outcome in the lives of our patients. So by way of introduction, clinical documentation refers to the process of recording and maintaining accurate, comprehensive, and timely information about a patient's medical history, treatment, and progress. You know, when you talk about clinical documentation, of course, there must be recording of information, either the history of the patient, the treatment plan, and also the progress of the patient and the day-to-day activities with your patients. And also the documentation must be accurate. It must be comprehensive. Anybody that reads it should be able to understand it, and it must be timely. Clinical documentation ensures continuity of care, supports clinical decision making, and means legal and facilitates communication among interdisciplinary team members, or it makes room for collaboration amongst the team members. We'll still talk about all this. So remember, our topic says documenting information in rehabilitation. We need to know what rehabilitation means. Rehabilitation is an important part of universal health coverage, and is one of the keys for achieving sustainable development goal 3 by 2030, which is to ensure healthy lives and promote well-being for all at all ages. That is Health for All 2030. So let's define rehabilitation. It's a set of interventions designed to optimize functioning and reduce disability in individuals with health conditions in interaction with the environment. You know, before you call yourself a rehabilitation expert, these 3 things must be in place in the course of your practice, your patient's management. You must work towards optimizing functioning for the patient and also reduce disability in that patient, and also integrate the patient into the society, into the community, into what the patient was doing before the problem started. That's when you would say that you are a rehabilitation expert. I'm sure there are so many of the rehabilitation experts here. I have a lot of professionals under medical rehabilitation. I have the physiotherapists, the speech therapists, occupational therapists, orthotists and prosthetists, most audiologists, all make up a rehabilitation experts. So in the course of our management, the management of our patients, all these 3 things must be in place. That's when you can be assured and you can proudly say that you're a rehabilitation expert. The rehabilitation helps a child, adults, or older persons to be as independent as possible in everyday activities, and enables participation in education, work, recreation, and meaningful life goals such as taking care of self and others. In fact, the hallmark of rehabilitation is at the end of the day, after managing your patient is independent as possible, and is able to go back into what he was doing before the problem came, and is able to engage in his or her day-to-day activities. Then documenting information in rehabilitation is crucial for effective communication. It's very, very important for effective communication between the health, multidisciplinary team, and also for continuity of care and optimize patients' outcomes. It's a critical component of providing high quality and patient-centered care. Remember, in rehabilitation, I've taught people about on ICF here. Rehabilitation is all about, ICF is all about rehabilitation and is patient-centered. Then accurate and comprehensive documentation helps rehabilitation professionals track patient progress to know whether the patient is improving. All these are very, very important. Also identify areas of improvement and make informed decision about treatment, whether to continue or whether to introduce new treatment modalities. Then the purpose of information collection and documentation in rehabilitation. The reasons why we collect and document information. In rehabilitation, the purpose of collecting and documenting information is critical for ensuring one, effective care, tracking progress by reviewing the patient to know whether there is improvement, whether you change the treatment you have given and add more, or you continue with the treatment you have given, and also meeting professional and legal standards. The key purposes include individualized treatment planning. That is to ensure the patient's condition, needs, and goals, and also develop tailored rehabilitation plans based on accurate and detailed informations. Tailor the treatment based on the need of the patient. And also monitoring progress, as I have said, to track changes in the patient's physical, mental, and functional abilities over time, and also to evaluate the effectiveness of interventions and adjust treatment as needed.
Hello, ma, we can't hear you. Hello, ma, we can't hear you. I don't know if you can hear me, but we can't hear you, ma.
Okay, can you hear me now?
Yes, we can.
Okay, can you hear me now? Okay.
We can hear you, ma.
We can hear you, ma.
When did you stop hearing me?
And when you change the slide.
Okay, okay. All right. Okay, let me continue from here. Okay. Interdisciplinary collaboration to facilitate communication and coordination among healthcare professionals involved in the patient's care. Makes room for communication among the health care professional, the professionals managing the patients, and also for legal and ethical compliance to maintain accurate records as required by law, regulatory bodies like MRTD and the professional standards to protect both the patient and the provider in case of legal and ethical issues and audits. No, like I said, that patients are now knowing their rights, quite unlike before because of the internet. In fact, before a patient comes to you, if the patient has gone to the internet to read about the case, the condition before coming to you. So in order to protect yourself so that the patient will not make money from you, so it's better you document properly, because in the legal courts, what they will use is the documentations that you have made. And another thing, ethical, we still talk about that, informed consent. We still talk about that because before you manage a patient, you must get informed consent from the patient. Then insurance and reimbursement to provide documentation required by insurers for claims and reimbursements. That's another reason why it's very, very important to document information, because the insurers, they use it to make their claims and their reimbursement of their money, the money they use in managing themselves. Then patient education and empowerment to provide patients with clear information about their progress and empower them to participate in their own care. Then research and quality improvements to contribute to clinical research, case studies, or quality improvement initiatives, classify patterns and best practices in rehabilitation. When the patient's information is well documented, one can use it to do research, like case studies. You know, I remember when I went through postgraduate college, we were asked to do 20 case notes, case studies. In fact, some of the case notes that I brought, But some of them, I couldn't make out something out of them. It's so frustrating. That's why all these are important. You can use the case notes to do research. So that's why it's good for us to document. And look, we are going to come to that. The things that are necessary for you to document in your case notes that are important. One can use it as research. One can use it to refer. What can can make us a lot of good things from a well-documented case note. And also risk management and safety. To document risk management and safety, to document potential risk and complications. Then continuity of care to ensure seamless transitions between healthcare providers or facilities by sharing accurate and updated patient information. It can be used, that is, if a patient is discharged and maybe after some time comes back again. The case notes, the information about the patient is well documented. It can make room for continuity of care. Or maybe the patient is transferred to another facility or referred to another specialty. It can make room for continuity of care. The person seeing the folder and the well documented will be able to, extract information that he needs if the informations are there. That's why it's good to document properly. Then prevents repetition. Targets diagnostic tests and treatment plans without unnecessary repetition. Let me say, for instance, I'm a physiotherapist. I ask my patient to go for CT scan. If I document it, maybe a medical doctor comes and look at the folder, maybe feel that the patient also needs CT scan. Saying it that I've already demanded for that, there will be no need for the medical doctor to come and demand for it again because I've documented it. So it will prevent repetition. And this will also help improve time management. Because when you're something that would have been somebody else would have documented well, I'll come and start doing it again. It will take time. Then accreditation. Accurate documentation is essential for accreditation purposes as it demonstrates compliance with regulatory requirements and standards of care. I remember sometimes when the MRTB, when they come to our center for accreditation, one of the things they do is that they go to the medical records and pull folders from there to know how we document our information that pertains to our patients. They pull them out and check all those things. So another one is evidence of patient's contact. You cannot say that you have managed your patients without documenting. That's an evidence. In the law court, that is that maybe a patient maybe claims that didn't come to see him or her. The evidence is your documentation. The next thing, the folder will be pulled and checked whether you really manage that patient, you have contact with that patient. It's also for record purposes. Then the qualities of a good documentation. One of the qualities there, or the qualities are, it must be correct. Anything you're documenting on the patient's folder, or maybe in your center, you're using a EMR or EHR, electronic medical recording, whichever one you're using, please, anything documented must be correct. Don't write the wrong thing. And it must be comprehensive. Anybody that reads it must understand it. Because you are not the only person making use of the patient's folder. And anybody that comes, just like as a physiotherapist, when you come, the next thing you do, in fact, before you start seeing your patients, you have to first of all look at what others have done before you came to know whether there is anything that maybe that can indicate you're managing your patients. You look at the consultant's review, look at maybe a dietitian has seen the patient before you, a speech therapist has seen the patient before you, any other. If the patient didn't document something in such a way that you understand it, you will not make meaning out of it. That's why you need to document your information so that anybody that sees it will be able to understand it. And also it must be patient-centered. And you must use a universal abbreviation. There are abbreviations that are universal. Don't put on the patient's case notes abbreviation that maybe you formed for yourself. Is not advisable. It must be consecutive. Whatever thing you're writing must be consecutive. Let's say, for instance, I want to write patients, maybe write PT. Continue to use that PT. Not after writing PT, you now write PAT. No. Whatever thing you're writing must be consecutive, so that the person that is reading it will not be confused. It must be clear, so that anybody that sees it will be able to read it. It must be legible. Somebody can read it. It must be contemporary. That is the current thing, not maybe something outdated. People are not using it. Bring it up again because people people will not understand it. Must be collaborative. That is said that another person coming to read it, maybe from another profession, should be able to understand what you're writing. Must be void of ambiguity. Don't use big words when you're recording or documenting your patient's information. Must be concise, simple, and must be complete. The general guidelines for clinical documentation. Documentation is required for every visit. Anytime you come to see your patient, you must document. Whatever thing you do for the patient must be written down. Like I said before, is an evidence that you have a contact with that patient. It must be well documented. Then all handwritten entries will include original signatures. After documenting, please put your signature. Put your signature. Then electronic entries are made with appropriate security and their confidentiality provisions. You have the password, you can use password. Then errors should be corrected by drawing, like if you're writing on the folder. So errors should be corrected by drawing a single line through the error, signing and dating the entry, or through the appropriate mechanisms for electronic documentation that clearly indicates that a change was made without changing of the original record. That is, if you're writing, talk about the case notes. If you make a mistake, maybe while documenting the information, you don't cancel. You don't cancel. What you do, just draw a line, a single line on top of it, sign and write date. All documents must include the patient's full name and identification. Let's say, for instance, like in UNTH, the case note that we use, each page or the continuation sheets, the details or the demographic data of the patients are all written there. You are the one that will fill it. That's what I'm trying to say, that you must fill it before you start documenting, because I had that experience when I told you I went to collect case notes for my case studies I wanted to do when I did my postgraduate fellowship this project. If they are not there and it pulls out, you won't be able to trace it. That's why anytime you want to document, all the continuation sheets, you must fill it. Write the patient's name, write the patient age, the hospital number, all those things. They're very, very important. So that if it pulls, it will be able to be replaced. Some of us, we don't really mind all these things. It's when I did that thing that I really knew the importance, the reason why they wrote all those things in each continuation sheet. So before you document, please make sure the patient's name is written on it. Everything required, they are all written there. Then all entries must be dated and authenticated with the therapist's full name and appropriate designation. Put the date when the patient was managed. All these things are important for medical, legal reasons. They are very, very important. Put the date, put the name, your full name, and your designation. That designation is also very, very important. Let's say, for instance, if you come to see your patient and then maybe you see house officers ward round, you may not take it so as important as when you see a consultant ward round. That one you pay more attention. That is also what happens when you put your designation. Maybe an intern comes to assess a patient and puts intern. Of course, you know that the one you should look out for is the maybe a more senior person. If a director comes to manage a patient, and maybe an intern has managed before, at least you pay more attention to the director's or somebody in the directorate cadre, more attention on the person's documentation than this. That's why it's good. It's very, very important. The designation is written there, but authenticated by a licensed physical therapist. Documentation should include the referral mechanism by which rehabilitation services are initiated. Example, self-referral, when the patient came on his own, direct access, that is self-referral, or request from consultation from another practitioner, maybe referred from another person. All entries in the paper health records should always be made in black and blue ink. He said that colors such as red, green, purple, and pink do not copy or scan well. So it's always good to use the blue or black ink. Then blank spaces should not be left in any documentation. Record and X. If there is any blank space, you put X there in the blank area to prevent the insertion, so that nobody will come and put another thing there. Prevent insertion of additional information that will be out of date or out of sequence. All blanks on consent form should be completed, because if somebody attaches anything there, it's binding on you that signed the signature. So that's why you don't allow any blank space. Put X there or fill it completely. Then areas of documentation in rehabilitation. You have home visits, clinic, hospitals. The reason why I put this is especially for this home visit. You know, like those that do PP. Sometimes we ignore these things. You don't document because you feel nobody there. You don't have any senior person that will check whether you documented or not. It's very important so that your patient will not use you to make money. Now, I've been saying this thing so many times now, repeatedly. Because any patient that knows that you are not documenting anything, you have not taken informed consent from that patient, the patient can sue you and make money from you. So you're both in the clinic, in the hospital, home visit, is very, very important. You document. Then ways of documentation. Manual entry, like I've talked about, is a paper and pen method of entering the data stored by filling in folders. Say legally, they are more acceptable as a documentary evidence, as these are difficult to tamper with. Then the disadvantage of this is that the need for storage areas and difficulty in the recovery of records in case there is maybe fire or there is maybe water pours on it, or maybe termites or all those things. To recover them back will be very difficult. Then electronic medical or health recording, EMR or EHR, that's another way of documentation. The medical records are computerized. These are neat and clear and can be easily stored and recovered, can be recovered faster than that of paper. These require a mandatory password protection and a backup system. You know, somebody can back it up on Google so that even if the computer spoils, you can easily trace it and recover it back. That's why it's more important. And I'm sure many centers are now using it because the advantages surpasses that of using paper. Access to this safety software is only given to authorized person. And improved efficiency. EMR can streamline documentation processes, reducing the time spent on paperwork. You know, in EMR, access are given to only those that are authorized to go. It's not something like, quite unlike paper. Using paper, anybody can easily go to the records and pull the folder. But for this, because of the password and the key lock, not anybody except those authorized cannot access it. Then enhanced accuracy, EMR can help reduce errors and improve accuracy through automated checks and alerts. Better communication, EMRs provide secure, real-time access to patients' information, facilitating collaboration among the rehabilitation team members. Then the policies and procedures for the storage of information in rehabilitation. The policies and procedures for the storage of information in rehabilitation focus on safeguarding sensitive data. That's the most important thing. Safeguarding sensitive data, ensuring compliance with legal and ethical standards, and maintaining the integrity and accessibility of information. And the key components of that are legal and ethical compliance. Makes room for confidentiality, that is adhered to privacy laws to ensure this secure handling of personal and medical information. Retention periods, follow regulations for how long information must be stored and define timeline for secure disposal. And authorization, ensure only authorized personnel have access to sensitive data. Then storage methods, like I said before, electronic storage. I use electronic storage. I use a secure electronic health records system. Implement encryption for data stored on computers, servers, or cloud platforms. That encryption means there is no third party who see it. It's only you and the person maybe you're sending it to. Then regularly backup data to prevent loss due to technical failures. When they are backed up, they can easily be recovered. Then physical storage, store paper records in locked cabinets in secure areas. We are talking about storage methods now. Then access control, authentication protocols require strong passwords, biometric verification or multi-factor authentication for access to electronic systems. Then role-based access, assign access permission based on job responsibilities, ensuring that individuals only access information necessary for their role. That is, nobody goes there without, except when the person has a role to play, maybe concerning the patient. Then audit trail, maintain logs of who accessed or modified information to monitor for unauthorized access. Security measures like cyber security. I use antivirus software, firewall walls, or regular system updates to protect against cyber threats. And conduct penetration testing to identify and fix vulnerabilities. Then physical security, restrict access to storage areas through key cards, locks. That is by locking this thing using passwords or security personnel. Then data integrity, accuracy checks, implement procedures to verify data accuracy during storage and retrievals. Version control, maintain clear documentation of updates or changes to stored information. Then disaster recovery plans, develop plans for data recovery in case of emergencies such as system failures, natural disasters or breaches. Then training and awareness, staff training, provide a regular training on data storage policies, cybersecurity best practices, and handling sensitive information. The staff should be trained in order for them to have the knowledge of all this. Then policy updates, keep staff informed about changes in legal, regulatory, and organizational requirements. Then data sharing and transfer, secure transfers, use encrypted communication channels for sharing data with authorized parties. That is encrypted, like I said before, that only the two parties are the ones that will see it. Inter-agency collaboration, define protocols for sharing information with external organizations. Ensure that, let's say, for instance, your facility, they want to share information, maybe patient needs to be transferred to another facility. That's what we are talking about. Define protocols for sharing information with external organizations, ensuring compliance with consent requirements. Incident response, breach notification, establish a protocol for notifying affected parties and authorities in the event of a data breach. Corrective actions, document and implement steps to prevent future incidents. Data disposal, secure deletion. Use secure wiping tools for electronic data and shredding for physical records. Then documentation, maintain a record of disposed data, including the method and the of disposal, and also the date of disposal. Periodic review and audit, policy review, regularly review and update storage policies to reflect changes in technology, laws, or organizational needs. Then compliance audits, conduct internal and external audits to ensure adherence to storage protocols. Be sure that everybody is doing the right thing, what he or she is supposed to do. And these procedures ensure the protection of sensitive information, maintain trust with clients, because the patient needs to trust you that you will not expose his or her information, and also uphold professional and legal standards in rehabilitation services. Then informed consent. What is informed consent? It's a decision to participate in assessment, treatment, or research taken by a competent individual who has received and understood the necessary, information. In fact, the patient will have to really agree with you, that you will carry on both in the assessment, in the treatment, or you want to use the patient for research, or you want to use the case note for research. If the patient is younger than 18, a patient or guidance will need to give the consent. If younger, the guardian will give the consent. Competent individuals should be provided with adequate, intelligible information about the proposed physical therapy. So before you see a patient, it's something that should be a routine. Sometimes we don't do it here, but it's very, very necessary. Like I said, now that people are, getting aware of, their rights, their rights. So informed consent is very, very necessary. In fact, if necessary, the most important is good is transcribed. It's good is transcribed, because if you just say it verbally, you don't have any evidence. If the patient maybe sues the rehabilitation experts, you don't have any evidence. But if it's written, well documented, you sign, the patient signs, you can present it. Yes, you gave the patient the information about what you are going to do, what you are about to do, and the risk involved, the benefits and everything. And the patient signs and says, okay. But I remember one time, there's one, I work in the pediatrics ICU. You know, the nephrologists, they came to see a patient, and there's one procedure they wanted to do for the patient. The consultants just told the patient's relation that look at what they wanted to do. I told the consultant, please, it's better they write this thing down. She's in fact that she has forgotten. In fact, immediately I said it, she said yes. So they have to really put it down in writing, because if anything happens, because that procedure is, you know, is 50-50, anything can happen with the procedure. So they have to write it down. So in such a case, anything happens, maybe patient dies, and they decide, they feel that it's the doctor that killed the person, you can easily, and maybe sue the person, you can easily bring it up. The patient gave the consent, I should go ahead. If a rehabilitation specialist attempts to treat a patient without valid consent, the patient may sue him in case of negligence. He will be liable under both civil and criminal law. The consequences will be payment of compensation in civil and imprisonment in criminal. In certain extreme cases, there is possibility of criminal prosecution for assault or physical contact with another person without the person's consent. That's another reason why chaperones is also very important. Maybe you want to see your patient, make sure there is somebody there with you that can be a witness. Don't go and start seeing a patient alone, especially when it has to do with opposite sex. Don't go and start seeing the patient alone. Make sure you are with somebody that can serve as a chaperone for you. This information should include a clear explanation of the planned assessment, the evaluation, diagnosis, and prognosis or plan, the treatment to be provided, the risk which may be associated with intervention, the expected benefits of the intervention, the anticipated costs, any reasonable alternatives to the recommended intervention. Then confidentiality of records. Confidentiality is the principle of maintaining the security of information elicited from an individual in the privileged circumstances of a professional relationship. It covers patients' physical and mental health, any clinical information related to individuals' diagnosis and their treatment, photographs, videos, and audio tapes. Everything that has to do with your patient must be confidential. You must seek the consent of the patient, and they must be confidential. I remember a day we went to see one of our patients. Patient has precious sore, and we needed to talk to a plastic surgeon that will see the patient, because the patient was referred to them and they were not forthcoming. And there's one that we know wanted, so the one that the practice surgeon said we should snap and send to him. And one of an intern just wanted to open up and snap. I said, no, it's not done anywhere. You must get a consent from the patient before you snap the patient. It's not done. So all these things are very, very important. We ignore them. And these are the things that can put somebody into trouble. Privacy violation healthcare sector include disclosure of personal health information to third parties without consent or inadequate notification to the patients. Please, it's not allowed at all. Don't disclose your patient's health information to the third party. It must be between you and the patient, or maybe you want to discuss it with the team that are managing the patient. Outside the team, it should not be disclosed. Outside, maybe you're in your office, you're talking about a patient. No, except maybe you're asking to find out what you will do for the patient that help to improve the outcome of the patient. If you just merely discussing a patient, maybe outside the hospital or to anybody is not done. I remember one day I gave somebody a ride. I was going home. One of our the person works with the records. So we saw somebody that was there waiting for free ride. That person working in the ride that I was carrying in my car was like, this person has HIV. This person has HIV. I was like, why telling me? Because you work in the records and you have the privilege to know what is wrong with the patient, with the person, and you are now announcing it everywhere. No, it's unethical. That shouldn't be done. Then unnecessary collection of personal health data. Provision of personal health data to public health, research, and commercial uses without the identification. The patient must know about it. If you give the consent that you can use the data for research for anything, you can go ahead. If the consent is not there, please, it's unethical. Then when disclosure of personal health information is permitted during referral, when demanded by the court or by the police on written requisition, when demanded by insurance companies as provided by the Insurance Act, when required for specific provisions of workmen's compensation cases, consumer protection cases, excuse me, or for income tax authorities, then communicable disease investigation and registration. Then demographic records. They are now coming to one of the main, how we document information, the things that are needed for you to document. Like when we talk about the informed consent, please, it's always good is transcribe and put in the folder. It's transcribed and put in the folder. And demographic records of the patient is also very important. Demographic data is an objective characteristics of a patient, such as the age, gender, family, size, present or prior disease, blood group, income, occupation, education, and residence. There's so many of things, even included both religion, all those things that are very, very important. One can decide to do a research on age. Someone can decide to do a research on occupation. If all these things are not documented, it will be very difficult for the person to do that research. So all these things are very, very important, both in your assessment, both maybe if you want to do your research, even in the management. Because if you know the age of a patient, it will guide you. If he's an adult, if he's because it's not what you do for a pediatric, is what you do for an adult. In so many areas, it's very, very important. Demographic data is very important. Uses this information help the healthcare team communicate effectively with patients, as well as understand the patient's culture. Maybe you know the patient's religion, you know the things that they don't do. Let's say, for instance, a Muslim, you know, with all this their covering, comes to you. Of course, most of the time they will not even allow a male to see their female. Maybe a Muslim man brings the wife to you. Most of the time, because of their culture, they will not allow a male to see that woman. That's why religion is also important. All these things may affect their health. Then challenges in rehabilitation documentation. One of the challenges is time constraints, because sometimes we'll rush our documentation because of time, because we have so many patients at hand to manage or to document their information. So we'll rush it. That is not good. Let's make out time and document properly. We've talked about a lot of advantages that are in it. Balancing thorough documentation with patient care. Then complex cases, managing detailed records for patients with multiple comorbidities. Then regulatory changes, adapting to evolving documentation requirements. Then standardized formats for documenting information in rehabilitation. So we are coming to how our documentation is supposed to look like. Standardized formats for documenting information in rehabilitation ensures clarity, consistency, and compliance across healthcare settings. These formats typically align with clinic guidelines, legal requirements, and interdisciplinary communication needs. In rehabilitation settings, thorough documentation and information collection are crucial for effective treatment planning and progress monitoring. And below are the main types of information typically collected and documented. For you to plan your treatment, you must assess properly, document properly. For you to monitor the progress of your patients, you must document properly. Because next time the patient comes, you go back to what you have done before. It will now enable you to know what to do next for the patient. In assessment documentation, first of all, we'll start with a subjective assessment. Subjective assessment, like I said before, informed consent. Before you start even touch the patient, produce yourself and get informed consent from the patient. And I said verbal consent is not really necessary. It must be transcribed. Your unit, your center, you can have a form. You can have a form the patient has to fill. You sign, the patient signs, that is authorizing you to continue in his or her management. Then the informant, so we are talking about how our case notes, our informations, the informations you need to ask, and those things, and how to document them, and the sequence you should follow. The informant, you have to put down the informant. If the mother is the father, maybe, or whoever the patient came from that is giving you the information, or maybe the patient himself, you must write it down. Then demographic data and hospital number, they are very, very important. This hospital number, and remember I said, in each of the continuation sheets, fill everything that are provided for you. The name, hospital number, age, all those things, sex, they are very, very important. In case any of the continuation sheet misses, you can easily replace it. Then date of the incidents, when it happened, you must put it down, because it will enable you to know how long the prognosis of that condition, when the patient it started and when the patient recovered. You now trace it, the duration is very, very important. Then date of admission should be there. Date of physical physiotherapy assessment, or whoever, maybe speech therapy assessment, or whichever the team. I'm putting down this because I'm a physiotherapist. You must put the date when you started, and also note the duration when the patient recovered. Then past medical history and comorbidity. Past surgical history, medication history, which include the name of the medication the patient is on, the dosage, the routes, the frequency, and the duration. All these things are very, very important, because there are some medications that may affect your patient's management. It's good to note all those things. The immunization history for children, obstetric history for children, family history, social history, dietary history, developmental history for children, allergy, then specific equipment or technology dependency, medical or referral diagnosis. Then we now put the presenting complaints. Somebody will be wondering, why did I put presenting complaints here? Because with all these things we've talked about now, the subjective history, from there, if the normal thing we've been doing is starting with presenting complaints. But the new thing now, even with the after that is American Physiotherapy Association, how they they put their their assessment. This is exactly how it is done. Because by the time you finish with all this, you'll be able to get the risk factor. The risk factor. When ask the patient, maybe a patient they have cerebral palsy, a patient with cerebral palsy, they ask the mother about the obstetric history, may tell you that when he's pregnant, that she fell down, which was pregnant, he was very sick, he had been took a lot of medications, all those things, or was not going for antenatal. You start, knowing where the problem came from. You'll be able to, in order for you not to be biased. Because if the patient tells you, okay, the child has maybe one side weak, or the patient cannot walk, cannot carry the head. The next thing is that all your mind will now be channeled that is CP, but it may not be CP. You understand? So, but when you ask all the histories, you now know the system you have to channel your assessment to before the patient now tells you the complaint, the presenting complaint. Then patient's history, when it happened, when the problem happened, where it happened, how it happened, what are the aggravating factors, what are the things that make the thing to the condition to calm down, where was the patient taken to, what did they do for the patient, which medication, and how the patient was referred to you. All these things will have to, these are the things to ask the history. Then objective assessment. Objective assessment, you have to find out the patient's major concerns and problems. Remember, we said in rehabilitation is patient-centered. In ICF is patient-centered. You need to know patient's concern, patient's problem. The patient has to tell you, so that so that your goal. Remember, I told us when I was talking about ICF that your goal must marry it with the goal of your patient. Let's say, for instance, your goal may be to strengthen the hand, but the patient's goal may be how to go back to typing. Maybe when the patient had an accident, her own goal is go back to her place of work and continue with what she was doing before she had that accident. But your goal is to strengthen the muscles. So you must note the concerns of the patient. Then check the vital signs, investigations that you need. Then or the ones that the patient has done before. Then general observation, inspection, palpation. Also use a package of intervention in rehabilitation. I'm sure somebody has taught us about this. The package of rehabilitation in rehabilitation, package of intervention in rehabilitation that has up to 23 rehabilitation domains. Then divide the body into 4 quadrants. You have the upper quadrants, you have upper middle, lower middle, you have the lower quadrants. All these things will help you in your assessment so that you don't forget anything. Know the target areas and the intervention for each domain affected. Then intra and the enter referral to other specialties when necessary. Referral is also part of the intervention. That, like, let's say, for instance, in the 23 rehabilitation domains, it discovers maybe a patient has an eye problem, and you are not the one to manage. You refer to an ophthalmologist. If you refer to the appropriate specialty area, it's also an intervention. So referral is an intervention. And let's say, for instance, a patient, a 2-year-old comes to you, and you need to observe more in order for you to really assess better. That observation is also intervention. Then physical tests, measurements, and outcome measures, they are also very, very important. State the exercise prescription using a FIT principle, that is frequency, intensity, time or duration of intervention. Assessments, prevention, treatment plan using ICF. We have talked about ICF here. Then note the highest functional level and their abilities at that level. You know, that's what ICF tells us or teaches us. You must note the functional level of the patient and take it from there. What are the things the patient can do at this level? He came to you. How to integrate it. What are the things the patient can do at this level? And what are the things you can introduce in the patient that will help the patient to participate? You go ahead and begin to work them out. Know the key issues and baseline factors, all those things that will impact the patient, that will make the patient progress to be delayed. Note all those things. Then, like ICF, the things you assess there: impairments, activity limitations, participation restrictions. Then look at the personal factors like age, like marital status, the lifestyle of the patient. You can have the barriers. Barriers are those things that will prevent the patient from functioning well. And the facilitators are the things that help the patient to function better. Then environmental factors. Look at the environment. What are the facilitators? Those things that will help the patient to function better. And the barriers. Let me say, for instance, in a patient that's on wheelchair and there is no ramp there, of course, it's a barrier in that environment. Then physical diagnosis is also very, very important. And as physiotherapists or other rehabilitation experts, we need to use ICF in our physical diagnosis. Let's say, for instance, instead of writing just stroke, patient has a CVA. Of course, you are not the one that will manage the CVA. Your diagnosis is based on the areas you're coming. Like I said here, you use ICF to make your physical diagnosis. Maybe a patient that has a quadriparesis. You can, from the assessment, you note the impairments you noticed, note the activity limitations, and the participation restrictions. All these things will make up your physical diagnosis. Then write maybe secondary to spinal myelopathy. That is the medical diagnosis. Then the problem list. You write the problem, the missing components in the problem, the patients that you see. Then on the reasons for the missing components, reasons for the problem. Sorry. Then the indicators. Which outcome measure do you use to measure it? Then after that, the ward or home program. Then put your name, your signature, and your cadre. Remember, it's very, very important anytime you manage your patient, so that if there is anything, you are the one that will be called. Then daily interventions. Patient's consent is, like I said, it's not something you do once. Anytime you come in contact with your patient to manage the patient, you must take consent from the patient. Date of intervention, very important. Intervention team, that is physiotherapists, physiotherapists must put it down. Patient's biodata and the hospital number, like I said, on this thing, on that continuation sheet, you must put it down. Then the vital signs must be recorded. Brief subjective assessment, objective assessment, and the prevention. Those things that you can introduce that will prevent further problems. But then the analysis of the problem, then plan of intervention using ICF. Putting down, bearing in mind the FITT, that is frequency, intensity, type, and duration of treatment. This SOAP method of daily intervention. Also, the use of assistive devices, the patient needs it. The modifications to the treatment plan. That is, remember we talked about monitoring progress of the patient. If there are things to modify, maybe add or remove from what you were doing before. Then barriers to progress. What are the things that are causing barriers to the progress of the patient? Note them if there is any. Then response and progress after treatment. Very, very important. At the end of each management, each treatment, please note this. It's the response of the patient and the progress after treatment. Then communication to other health care providers and referral if there is need for that. then ward or home programs. Bearing in mind the fit principle, then your name, signature, and cadre, also very important. Then discharge summary, date of discharge, intervention team, patient's biodata and hospital number, like I said, referral diagnosis, prior level of function before the incident, summary of assessment from onset, subjective or objective, summary of treatment plan from onset, patient status, initial assessment and condition at discharge, then home program, follow up and the outpatient visit. Put your name, your signature, and your cadre too. So in conclusion, effective clinical documentation in rehabilitation is crucial for ensuring high quality patient care and achieving optimal functional outcomes. Proper documentation ensures compliance with legal, ethical, and professional standards. Bearing in mind that patient's report will be read at some point by other healthcare providers. Like I said, you are not the only person that reads the case notes. Every other person managing the patients also have to read the case notes. So you have to document properly, either during the current intervention or in several years time, it should be well documented. Even if it's not that period, somebody can maybe in several years to come and use that for research or for referral purposes. These are my references. Thank you for listening.
Oh, thank you so much, Ma. Thank you so much, Ma. We appreciate. I don't know if I have any question. If you have questions, this is the time to ask your question. Please raise a hand. Just raise your hand if you have a question. I will unmute you. Then you unmute yourself and speak. Any question? Okay. All right. You can go ahead and speak, Ma.
Good evening, everybody. Thank you, Ma, for the lecture. It's quite timely. My question is with the new policy that MRTB wants to bring up in terms of documentation, because there is this particular, it's still tentative, like they are still debating it, that we should align with the international standards of evidence-based practice, that will not need to be documenting. We just, for every particular condition, you fill the form, you fill the outcome measures, it helps with document. So I don't know if when that comes in place, whether documenting, because we all have different ways of documenting. Some people like to document with shorthand writing. Others will want to go in depth. I think with that idea, the idea of the MRTB of having a universal kind of documentation will be ideal. But I want to know your take regarding this, because I think you are also part of the stakeholders. Thank you, Ma.
Okay. Thank you for that question. It means people are really paying attention. Like the new method that MRTB, because like our registrar wants it to be like everybody in the country will be doing the same thing, will document, with the same pattern. But everything I've written here, but I wrote this thing before we had that our workshop. I presented this thing last year too. But I just noticed from that thing that that form, everything here is written there. Of course, we'll have to go by what our registrar said, that is using that form. But everything in that form, they are all here. But just that one is a concise way of doing it, which is better. We talked about one of the challenges is time constraints. I think with that form, it will help to solve that problem of time constraints. Thank you. I hope I've answered you.
Yes, ma. Thank you so much. But I also wanted to say, isn't it possible to leave a particular space for any other thing, just in case after filling the concise form, then you have additional something to write? Because I was looking out for it. I didn't see it in that tentative. Additionally, you can add something that is not on that form that you think should be useful or something. Thank you.
Okay. As regards to that form really, I remember our registrar said something that it's everything is not just those things. If there are other things that that they are important, you need to document that are not there, you can still go ahead and do that. I remember him saying that kind of a thing. So you must not just follow it just exactly the way it is, but he's just telling that everything there, you must capture everything there. But if they have maybe any other things that that are important for you to assess or for you to do as regards the patient management, you can also you can also add. I think I heard him saying something like that. So you must not just follow it that way. Do you understand? Or maybe you were not there when he said something like that.
Okay, ma. I get it now. Thank you. It has explained everything. I didn't hear him say that. Maybe it was when the network pushed me out or something. Thank you.
All right. Thank you so much, Ma. Thank you for explaining this so well. Indeed, documenting is very much vital. Yes, it's very much important. Just in case there is an issue, we have a proof. It's our evidence. Yes, because some patients can actually deny you and they'll just want to do things on their own favor. But then documenting it rightly and then storing it and saving it in the right way help us in case of any future occurrences that will need an evidence to actually save us and also protect our profession also. Thank you so much, Ma. I think that will be all for tonight. I don't think anyone else has a question. So Bitidera, do we have any other info? Any other info we should know about?
Good evening, ma. There is no input from my end, just the quiz link which has been sent to you and your co-secretary. But I also like to reiterate that quiz links are not sent to the group chat. Please. Quiz links are not sent to the group chat. This is to all the participants. They can only be sent here on the Zoom chat box, and for those that are streaming via YouTube, it will be dropped in the YouTube chat box. So do well to copy the link immediately it is dropped. And if for any reason you get dropped off or you couldn't copy it or just any reason at all, just reach out to the secretaries to sort it out. Nobody sends any link in the chat, in the WhatsApp group chat, please. Let's take note. Thank you.
All right, thank you so much. So the link has been dropped already in the DM chat here in the Zoom, not in our WhatsApp group chat. So just check your chat, just under your phone, you see many icons there. Check the chat, then you see the link to the quiz. And please don't leave immediately. Make sure maybe you can just go straight to answer the questions, or you can copy the link and save to somewhere. But please don't send it to the WhatsApp group. Yes, I think that will be all for tonight. Thank you so much, everyone, for coming, and do have a beautiful night rest.
No, I saw one question at the chat box. Let me just talk about it. Somebody said,
Okay, ma. Yes, go ahead, ma. Sorry, it was an oversight.
I saw 16, like I said, 16 years. No, please, as maybe the age range for children. No, it's 18. I said 18. It's there in the distance. I sent you the slide. It's not 16. Maybe, I don't know whether I said 16, but I know it's 18, and it's 18 that is in the slide. That is for adolescents. Yeah, that is for them. Because what I said there is that if for informed consent, if the person is below 18, then is a caregiver that should give the consent, or if it's a child, patient can give an assent form to fill. But if the person that is qualified to give informed consent is the caregiver for the minors. So thank you. It's 18, not 16, please. Okay.
Okay. All right. Thanks so much, ma. All right. Okay, we'll resend the link. So please, we've come to the end of class. You can exit the chat and answer the quiz immediately. Thanks so much. Good night, everyone.